Recently, I've been getting back into listening to the clinical problem solvers a lot. Every time I've listened to an episode, anytime I learn anything, I try to make new Anki flashcards. And some of the things can be pretty simple and pretty basic things, but things that I feel like I should be able to remember more. So when I am doing clinical problem solving exercises, I'm able to bring them up, for example, in morning report and things like that. Here's a huge list of all of the podcast episodes. And I've pretty much listened to all of the RLR series episodes that are available just in this past month. And since then, I've started going through basically all the videos that I can that are clinically focused. So if you look on Spotify, I believe it starts from episode 190 or so. And now I'm trying to go from the very bottom up. And it's kind of nice to just solely focus on one podcast and just try to get as much information as I can out of it. There are some times where I feel like I've preferred other podcasts over clinical problem solvers because clinical problem solvers is much more diagnosis focused, whereas another podcast that I really like, the Core IM podcast, has a lot more like very quick high yield and very short high yield pearls. But I also really just like the practice of clinical problem solving, going through the diagnostic process, and just like trying to figure out what the patient has is so fun. So basically, it's just been really great to focus on one podcast and really just try to get as much as I can out of it. So I wanted to kind of take you guys through some of the cards that I made over this past month. And some of it, again, is very basic, but I just feel like there's so many nice little pearls that you can learn just from passively listening to this podcast. And if you make it a habit to make cards whenever you learn something new, you hear something and you just take a note. Either if you're driving, just make a mental note to write it down later and then make an Anki flashcard out of it, or even just actively having your Anki up while you're listening. Just try to compile that information that you learn. And I feel like it's so useful for being able to pull that information up in the future and also be able to retrieve it just, with all the spaced repetition and everything. That's really the power of doing your spaced repetition. All right, so just starting out with some of the cards that I made over the past month. So what rule is there that can be used to estimate how much heart rate should elevate during fever? This is something that's commonly used in the clinical problem solving space, and it's called the Liebermeister's rule. And so for every increase in 1 degree Celsius from a normal temperature, heart rate should increase by 8 beats per minute. And this can be useful for you to figure out if somebody is having something like temperature pulse dissociation, also known as Faggot sign, which you may see in some infections like typhoid, Legionella, Q fever. Those are some of those things that cause that pulse temperature dissociation. Why might vitamin B12 assays be falsely low or high in the setting of pernicious anemia? So I learned that B12 assays are actually pretty unreliable, and it's because the assay relies on intrinsic factor. And so even in patients without pernicious anemia, it can have some false negatives and false positives. So anyways, if they have pernicious anemia, it's going to cause antibodies against intrinsic factor, which may cause frequent errors. What time frame is antiviral treatment indicated for immunocompetent adults with shingles? This is something that I encountered on my wards, and so that's within 72 hours. So within 72 hours, you want to start valacyclovir or famciclovir, which is preferred over acyclovir, since acyclovir is 5 times daily. And if it's after 72 hours, antiviral therapy is still indicated if there's a lot of uncrusted lesions and you have selected patients that are immunocompromised. They have, complicated areas like the V1 dermatome, advanced age, other things like that. In terms of a central DI versus nephrogenic DI, which one is more common? So central DI is more common. What do teardrop cells indicate on peripheral blood smear? And I really like the way that they explain this on the podcast, but it's like the bone marrow is crying. And basically, it's telling you that there's fibrosis or invasion or infiltration of the bone marrow. So some of these diseases that can cause this are granulomatous diseases and cancers and things like that. So whenever you see those teardrop cells, think about invasion of the bone marrow. Does amiodarone have antiarrhythmic properties against all 4 classes? The answer is yes. So it's primarily a class 3 antiarrhythmic, but it actually has effects in all categories. And I just learned this today. So amiodarone is nerdy. It likes to attend all the classes. So it's just something interesting to remember because we learn about these classes, and it's useful to know how amiodarone actually works. And it works by actually really kind of broadly hitting everything. What is an important test to get in somebody with pancytopenia before giving transfusions? The answer to that is going to be a peripheral blood smear, because you want to get the blood smear before you transfuse them with normal blood, which may impact your peripheral blood smear. In a patient with anemia and gastrointestinal pain, what does a high ferritin suggest about the source of anemia? So you have some concern for GI bleeding, they've got some GI pain, they're anemic. Well, if their ferritin is high, then that suggests that the anemia is not related to GI bleeding. So this is because if it has GI bleeding that is causing anemia, you would either see overt bleeding, that's just very obvious, or if the bleeding is slow enough to not be overt, you would see low ferritin, because this would be like a chronic process. So high ferritin is reassuring against a GI bleed. How good is an X-ray for looking at a possible necrotizing infection in the foot compared to CT? Apparently an X-ray is fairly good, just because there's not that much soft tissue in the foot, that the X-ray by itself can be pretty valuable in determining if there's necrotizing, concern for necrotizing infection. How does the troponin ejection fraction product help differentiate takotsubo cardiomyopathy from acute coronary syndrome? And this is something that's actually published in the literature. So there's this thing called the troponin ejection fraction product, and it's low in takotsubo. That's because these takotsubo patients tend to have very low EF, but they don't have a consequent very high elevation in their troponin like you would see in ACS. So a troponin ejection fraction product value of greater than 250 had a sensitivity of 95 and a specificity of 87% to differentiate a true STEMI from stress-induced cardiomyopathy. Can you see white exudates on EGD with a negative biopsy for esophageal candidiasis? So this was a case where there was a lot of exudates on the in the esophagus on endoscopy. And the question was, did this patient have candida? And they got a biopsy and it was negative for candida. So was this like a false negative or something? So the answer is actually yes. So actually the biopsy is very, very sensitive to diagnosing candidiasis. So there are a lot of other causes in just normal esophagitis where you can get white lesions and exudates. If you have a negative biopsy for candidiasis, then you can trust it. Basically, it's so accurate that you should be fine. Why should you be concerned in a patient with weight loss and worsening edema? This is an old one that I've learned a long time ago, but I just thought I'd make a card on it just, to have that spaced repetition of this one, because it's an important teaching point. So if somebody is having worsening edema, you would expect them to be gaining weight. Heart failure patients, they're accumulating fluid. Cirrhotic patients, they're just getting fluid overloaded. You get weight gain. So when you have weight loss and edema, this is telling you that the amount of weight loss they're having is likely underestimated. So they're actually losing a ton of weight if you're seeing some weight loss and worsening edema. So it just kind of just underscores how much weight loss they're having. What is a useful clue for neurogenic orthostatic hypotension rather than non-neurogenic from volume depletion? So I had a lot of patients who recently had very severe orthostatic hypotension. It's a very difficult diagnosis to manage, to be honest. But you'll find that there's categories of neurogenic versus non-neurogenic. And in the patients with neurogenic orthostatic hypotension, which is, for example, due to autonomic dysfunction or severe diabetes with dysautonomia, Parkinson's, things like that, they do not have a heart rate increase when you stand them up. Whereas somebody who has orthostatic hypotension because they got dehydrated or whatnot, they've had poor PO intake, they still have that sympathetic tone intact. So when they stand up and their blood pressure drops, they still have that appropriate increase in their heart rate. In terms of TB, this one's a pretty obvious one. And honestly, we all know this, but in this case, there was a learning point that TB can obviously normally causes caseating granulomas, also known as necrotizing. So the first thing is that they had mentioned it as necrotizing. And so you need to know that caseating and necrotizing are pretty much the same thing. But just because you see non-caseating or non-necrotizing granulomas does not mean that it can't be TB. So we know that TB is associated with caseating granulomas, but in this specific case, they had a non-caseating granuloma and it still ended up being TB. So something important to keep in mind. Should patients with orthostatic hypotension and supine hypertension have their head of bed elevated? This is a good practice just to reduce supine hypertension. What 3 conditions should you consider in patients with symmetric pathology of their dorsal column? So patient is coming in with kind of this unstable gait or difficulty walking, and you find diffuse edema in their spinal cord in the dorsal columns. So the three things to consider are syphilis, vitamin B12 deficiency, otherwise known as subacute combined degeneration, or copper deficiency. So good to have just like a quick differential for that. Why can it be difficult to identify signs of septic joint in the hip compared to the knee? It's because it's a deeper structure, so you're less likely to see erythema and swelling. So it's very important to do all the other exam maneuvers like range of motion to check for possible septic joint. What is a good way to gauge if a patient is having physiologic versus pathologic weight loss? This was a kind of funny one that I was just listening to this morning, actually. But basically, this patient came in and they had like 100 pounds of weight loss. And at the same time, they were having like a lot of shortness of breath and other respiratory symptoms and things like that. And basically, Robbie was like, he calls it the high 5 rule. So if you hear about a patient's significant weight loss and your initial response is to give them a high 5, it is probably physiologic and intentional. If your initial response is not to give a high 5 and you're like concerned because they have all these other symptoms going on and respiratory symptoms and things like that, then it's more likely to be pathologic. I thought it was kind of funny, so I thought it was kind of a funny way to put it, and potentially useful, right, when you're teaching somebody. When is it appropriate to ask neurosurgery to tap a VP shunt? So I just recently made that video on that, but this is because this happened while I was on the rounding service. And so again, it's concern for shunt infection or concern for shunt malfunction. What is the main difference between fever and hyperthermia? So fever is when your hypothalamus is actually increasing the temperature set point of your body in an effort to fight infection or respond to inflammation or things like that. Whereas hyperthermia is actually kind of like an external problem where your body is unable to cool itself down, and there are external environmental factors that are causing your high temperature. So temperature set point is elevated in fever due to inflammatory mediators, whereas in hyperthermia, the temperature set point is normal. However, the body is in an environment where it is overwhelming the ability to self-regulate. Can you still see kidney stones on a CT scan with contrast? So we all know that a non-contrast CT abdomen pelvis is what's preferred for identification of kidney stones, but actually CT scans with contrast are apparently still very sensitive for finding kidney stones. And so this is a useful kind of pearl for me. Is takotsubo cardiomyopathy associated with prolonged QTC? The answer is yes. So something useful to know if you see a case of suspected takotsubos and you see that prolonged QTC. Why does the terminal ileum have a predilection for inflammation? So this comes up a ton in morning reports and case reports and things like that, but a lot of people just end up having inflammation, edema, just, a lot of pathologies that involve the terminal ileum. And the reason for that is because it's very immunologically active. And this is because this is where those Peyer's patches are, that we learned about in medical school. So immunologically active diseases love to show up in the terminal ileum. For example, Yersinia, Salmonella, TB, non-TB, mycobacterial infections. Autoimmune conditions, also very immunologically active, so vasculitides, inflammatory bowel disease, spondyloarthropathies, and then malignancy is another possible cause of, if you see significant ileal involvement, you might be wanting to think about some of these conditions. So a neuropathy that affects multiple individual nerves, but not in a symmetric pattern. This is called mononeuropathy multiplex. And so they actually have a framework for the evaluation of peripheral neuropathy. And it starts off with mononeuropathy, which is often from compression, for example, carpal tunnel syndrome, cubital tunnel syndrome, things like that. And then mononeuropathy multiplex can be due to inflammatory causes, malignancy, hereditary causes. And so basically you have like randomly distributed nerves that are affected, but it's not in a symmetric pattern. The polyneuropathy that we see that's kind of symmetric lower extremities, symmetric hams, things like that. These are the kinds that we see very frequently, like diabetic neuropathy, things like that. Does central DI or nephrogenic DI tend to be more acute in presentation? And I believe, was it nephrogenic was more acute, or central DI? Central DI tends to be more acute in presentation. So another useful thing to know. What is the mortality of acute promyelocytic leukemia if not treated early? It's very high. So if you have any suspicion for APML, you should have a low threshold for giving all trans-retinoic acid and arsenic if there is any suspicion for it. But it is curable with the appropriate treatment. So it does have a good prognosis if you start them on good treatment right away. Is it likely for unilateral hydronephrosis to cause significant AKI? So in general, if you just have one side of hydronephrosis, you're probably not going to see a huge AKI, and you might want to go digging for other causes of their AKI. Because if you think about it, a patient who has a kidney transplant literally has one of their kidneys, they only have one kidney, or somebody who has a nephrectomy rather, they only have one kidney and they still have relatively stable creatinine. So yeah, if there's a patient who has a significant AKI and there's like mild hydronephrosis in one kidney, that you might want to go digging a little bit for other causes of their AKI. Leukocytoclastic vasculitis is synonymous with small vasculitis and is called that because of what finding. And I just wanted to have this teaching point in case I have another morning report. I can tell people why it's called leukocytoclastic vasculitis, but it's because of the finding of white blood cells or neutrophils in and around the blood vessels. So it just gives you some context to why we call it that. What are some adjunctive treatments to help address methamphetamine withdrawal in the hospital? I learned this from my psych intern actually, but there is evidence for trazodone, Benadryl, Zyprexa, even Ativan if needed, and even vitamin C apparently is helpful. And then a huge part of making patients with meth withdrawal more comfortable and more willing to stay in the hospital to receive care rather than getting withdrawal symptoms and wanting to leave right away, is promoting their sleep with these medications, and then also providing excess food. So they get these very, very strong hungers when they're going through the withdrawal phase. And so double portions for these patients can go a long way to helping them stay in the hospital to receive their treatment. What lab finding is most suggestive of cirrhosis? If you were to choose just one lab finding, the answer to that would be thrombocytopenia due to low thrombopoietin and splenic sequestration. Why should you assess if flank pain hurts with movement or not? So if somebody has like CVA tenderness, if it does not hurt with movement, it's going to be more likely to be like from the kidney. Whereas if it does hurt with the patient moving around and such, that's going to be more musculoskeletal. So true flank pain does not hurt with movement. Back and muscle pain does hurt with movement. What are the two most common causes of hemorrhagic strokes in elderly patients? This is something that I learned on neurology, but it's always good to make a refresher Anki card if you need to. So the two most common causes are going to be hypertension and cerebral amyloid angiopathy. So hypertension is going to be happening mainly in those lacunar structures, the deep brain structures. Whereas if you see microhemorrhages out in the periphery, that's going to be more cerebral amyloid angiopathy. A patient with suspected endocarditis without overt symptoms but severe valvular regurg likely has what kind of endocarditis? This was a case that was presented on Clinical Problem Solvers. The patient had like severe aortic regurgitation, but otherwise they were pretty much tolerating it pretty well. And then you found that they had like positive blood cultures, or they basically found that there was like a very high suspicion for endocarditis. And so usually if you have this kind, it's probably going to be a culture negative endocarditis or subacute endocarditis. For example, Bartonella, Coxiella, brucellosis. And that's because staph and strep, they tend to be acute endocarditis. The patient would not be tolerating this like huge regurg all of a sudden. The reason they can tolerate it in these culture negative endocarditis is because it progresses so slowly that the body has time to adjust to the poor cardiac function and the valvular regurg that's going on. What test is often important in the diagnosis of rash? This is just a skin biopsy. Remember that tissue is the issue. Disseminated herpes zoster is defined by involvement of how many dermatomes? The answer to this is greater than 2. So actually, if they just have 2, that's not technically considered disseminated herpes zoster, but if it's greater than 2, or if it's crossing the midline, or if there's 2 non-contiguous dermatomes, then that's consistent with disseminated herpes. And I all learned this because I had a disseminated herpes patient this month, and there's a lot of learning to be had just looking this up. And so these patients should be treated with IV acyclovir rather than oral until lesions are improving and crusted, at which they can transition to oral treatment. Diffuse lymphadenopathy, polyclonal gammopathy, and skin changes would be consistent with what condition? That would be Castleman's disease. And they may see very extremely elevated inflammatory markers such as CRP in the 300s. So the key part for this case was the skin changes and the presence of cherry angiomas. So if you see this diffuse lymphadenopathy, concern for malignancy, and cherry angiomas, think Castleman's disease. How do lupus, chronic infections, and vasculitis affect complement levels? This is something I just made to quickly access this, but yeah, it causes low complement levels. So this is just like a reminder card, essentially. Why does neurosurgery tend to be hesitant to tap VP shunts? We addressed that in the video, but it's not a benign procedure. Risk of infection or damage to the system could require removal, EVD placement, and days to weeks in the hospital before it's replaced. Brain aneurysms distant from the circle of Willis are concerning for what kind of aneurysm? The answer to this is going to be a mycotic aneurysm. So usually, if somebody has a brain aneurysm or a berry aneurysm or whatever, usually they're more proximal. Usually they're near the circle of Willis. But think about endocarditis when you're seeing aneurysms more distally. Why can a leukemia cause dry tap on bone marrow biopsy? Leukemia, aren't we expecting a ton of cells present? So shouldn't you see a bunch of blasts and things like that? Well, sometimes there can actually be so many cells in the bone marrow that it's really hard to actually just get an adequate sample because there's too many cells present. So a dry tap on bone marrow biopsy does not necessarily mean you have an empty bone marrow or fibrosis or myelofibrosis, things like that. It could still be leukemia. What is a good way to remember the main categories of chronic myeloproliferative diseases? So Robbie taught that just looking at your CBC, so on the very left, you have your white cells. So that would be like CML, chronic myelogenous leukemia. Then on the top, you've got your hemoglobin. So you've got polycythemia vera. On the right, you've got platelets, essential thrombocytosis, or thrombocythemia. And then on the bottom, you've got your hematocrit. That's where you can kind of put a throwaway one, which is myelofibrosis. So CML, PV, ET, and myelofibrosis. What are two immediate and important questions to ask whenever you see significant thrombocytopenia? The answer to that would be, is there any recent exposure to heparin? Because this is going to change management if you're concerned for HIT. And is there any schistocytes? Because if they have TTP, HUS, or any of the MAHA kind of family of disorders, they're potentially going to need plasmapheresis. So any recent heparin exposure and any schistocytes. What guidelines suggest against treatment of asymptomatic bacteriuria in elderly patients with delirium? That's going to be the 2019 IDSA guidelines on asymptomatic bacteriuria. Studies have shown that antibiotic treatment does not lead to improved outcomes, but there has been associated longer length of stay, worse recovery, no difference in resolution of delirium 7 days later, and there are known risks of harms such as antibiotic resistance, C. diff, side effects, etc. Suspicion for leukemia plus elevated D-dimer and INR. Immediately, you should be thinking about APML because this is basically telling you that DIC is likely present here. What kind of compression stockings should patients with orthostatic hypotension have? This is going to be thigh-high compression stockings because, again, I had all those orthostatic hypotension patients and they all had knee-high compression stockings. This is a good reminder that you really want to have the really high compression stockings to really adequately treat their dysautonomia. What is one of the first questions to ask when a patient presents with fatigue? This is another clinical reasoning kind of question. And the question to ask is it worse with exertion? So if it is worse with exertion, you automatically can reframe their fatigue as dyspnea, which could make you consider instead the cardiac, pulmonary, and hematologic symptoms. If it is non-exertional, then it could be a lot of other things, but like depression, hypothyroidism. But that exertional fatigue, you should just kind of translate to dyspnea. What are general categories of things that can cause problems to present hyperacutely? So there's three main things that can cause severe decompensation, sudden decompensation. That would be a rupture, a blockage, or a sudden discharge of electrical activity. So there's also a rapid action of a molecule like histamine, like anaphylaxis or insulin. But in general, if somebody very hyperacutely decompensates, these are some of the things that you should really have on your radar. What is a medication that might explain why a hyperthyroid patient isn't overtly hyperthyroid, like they're not very symptomatic from it? You need to check if they're on a beta blocker, because that's going to be masking a lot of the effects of their hyperthyroidism. Can urinary tract obstruction cause a temporary nephrogenic DI? And actually, it's very common for an obstruction to cause temporary nephrogenic DI. And so this is partly why we see some of that post-obstructive diuresis. And I actually had a patient who had quite significant post-obstructive diuresis for 5 or 6 days. And basically, they were having this nephrogenic DI picture afterwards. What is the most likely etiology for a single cytopenia versus multiple cytopenias? So when you have a single cytopenia, you have to think of a peripheral process that's affecting the patient. The more cytopenias that you add on, the more you have to think about a central process in the bone marrow itself. So if you have one cytopenia, it's likely periphery. 2 cytopenias is likely periphery, but could be the bone marrow. And 3 cytopenias, most likely is going to be the bone marrow. Could be hematologic cancers, autoimmune diseases, and some tick-borne illnesses as well. Why can leukemia cause pancytopenia even though there is proliferation of blasts? Don't you expect to see extremely elevated white blood cell counts and just high cell counts in general because you're just overproducing cells? Well, the problem is these cells are very unhealthy and they may die. They just kind of undergo apoptosis. They don't make it out of the bone marrow. And so a lot of patients will not necessarily have, sky high white blood cell counts. This is the reason why sometimes they're just like pancytopenic when you see them. What is it called when you have microscopic blockage with kidney stones that may not be seen radiographically? This is called nephrocalcinosis. And so most of the time you see stones in the collecting system because that's where the calcium gets the most concentrated, and then you get nephrolithiasis. But if you have extremely high levels of calcium, oxalate, or uric acid, you may actually get things that you can't even see radiographically, and it can explain an AKI if there's suspected nephrocalcinosis. What are tumor markers like CA125 most useful for? Are they useful for diagnosis? The answer is no. They are useful for assessing treatment response and also for prognostication, but not for diagnostic processes. So almost anything inflammatory in the abdomen will raise the CA125. So this was a case of a patient who had abdominal TB and had really elevated CA125. Is cisplatin or carboplatin associated with higher risk of cytopenias? The answer is carboplatin. Cisplatin has a higher risk of just feeling ill in general, and then AKI and ototoxicity. And it also requires more pre and post hydration. Is encephalitis or meningitis more likely to cause altered mental status? That's going to be encephalitis because the brain parenchyma itself is inflamed rather than just the meninges. How is IgA vasculitis diagnosed? Is it diagnosed by a biopsy or things like that? So actually it's clinically can be diagnosed by the presence of palpable purpura and then 2 out of 3 of the classic findings, which would be arthralgias, kidney disease, or abdominal pain. So palpable purpura, 2 out of 3 features, and then biopsy of the affected organ can also confirm the diagnosis. Treatment is NSAIDs and steroids, removal of offending agent if present. Should you be cautious choosing antibiotics when treating Citrobacter frundi, Enterobacter cloacae, and Klebsiella aerogenes? The answer, and yes, I definitely did mispronounce those, but yes, you should be careful choosing them because you may be misled on what they're susceptible to. So these have inducible AMP-C beta-lactamase resistance. So if you give them ceftriaxone, let's say it says it's susceptible to ceftriaxone, it can actually induce resistance to beta-lactams, and then all of a sudden, you now have created a more resistant organism, and the antibiotics are not going to work. So previously, we had this spice mnemonic, which was these kind of AMP-C inducible organisms, so Serratia, Providentia, Proteus, Citrobacter, Enterobacter. Now it is more favored to use this heck yes mnemonic. So heck yes is Hafnia, Enterobacter, Cloacae, Citrobacter frundi, Klebsiella aerogenes, and Yersinia enterocolytica. And so even if it says susceptible to ceftriaxone, got to be very careful about giving ceftriaxone to these patients. So consider 4th generation cephalosporins or carbapenems instead. What if a patient has erythema in the foot that worsens with gravity and x-ray shows microfractures? This is acute Charcot arthropathy, and it's very similar to complex regional pain syndrome. They get these vascular skin changes, hyperemia, sympathoplegia, and bone changes. And basically, this is a very interesting case, but the treatment is complete non-weight bearing to prevent complications. Can crystalline diseases like CPPD manifest in the spine? The answer is yes. And interestingly, there's a condition called the Crowned-Den syndrome, which is when it can accumulate in the posterior neck and cause severe occipital pain, neck stiffness, and calcification of the C2 vertebral body. What is the etiology of amiodarone-induced thyrotoxicosis type 1 and type 2? And furthermore, on top of that, what is the difference in how we treat these patients? So type 1 is going to be typically in patients who have an underlying thyroid disorder. It is treated with thyroid medications, and it's basically an iodine-induced hyperthyroidism. Whereas type 2 is a destructive thyroiditis, where it's going to cause a lot of release of preformed thyroid hormone, and the treatment is with steroids. So type 1 is iodine-induced hyperthyroidism. Type 2 is destructive thyroiditis. The treatment is different for both of these. Okay, and if you look here, type 1 tends to be more recent onset, whereas type 2, generally patients are on the amiodarone for much longer. What are some possible treatments for neurogenic orthostatic hypotension? So there's some kind of off-label treatments that we were kind of reaching for in these severe orthostatic hypotension patients, but it's like droxidopa and pyridostigmine, which are kind of used for like Parkinson's patients with severe autonomic dysfunction. So something to consider when you're really at the end of the line. What exam maneuver is helpful to assess for vertebral osteomyelitis and discitis? It's going to be percussion of the spine, not just palpation alone, because percussion may be better at eliciting tenderness. What is a framework for causes of pancytopenia? So on the Clinical Problem Solvers podcast, they like the 4S framework. That is going to be systemic, so like a systemic infection or a systemic autoimmune condition that's causing pancytopenia. Substances, so either you have alcohol suppressing your bone marrow, or you have basically not enough of a substance. For example, you don't have enough copper or iron or folate B12, things like that. Then it's going to be space occupying. So is there some invasive process that's occupying the bone marrow, like a granulomatous disease? And then 4 is going to be stem cell disorder, which would be like a leukemia. So systemic, substances, space occupying disease, or stem cell disorder. That's a nice framework for pancytopenia. And is acute fatigue or chronic fatigue more likely to be from a medical condition? That's going to be acute fatigue. So acute fatigue and chronic fatigue, chronic fatigue, a lot of people have chronic fatigue, and a lot of times they're from non-medical conditions. Chronic fatigue certainly could be from a medical condition, and there's a lot of reasons for chronic fatigue. But if somebody is coming to the hospital with acute fatigue, you're going to be a lot more concerned about something acutely changing in their medical picture. All right, so those are a bunch of the little pearls that I learned over the past month through, taking care of patients and writing down pearls that I learned while taking care of them. And then also just going through all the podcasts on clinical problem solvers and just writing down things, when I was able to prompt myself and remember what I was listening to in the car, I would just go back and then I would make a quick card on it. And I think having this process in place, having this practice in place really helps you to solidify this information and be able to recall it in the future when you need it for taking care of patients, or especially for me in the case when you're trying to teach others or do clinical reasoning exercises like morning reports and things like that. So I highly recommend you develop a system like this. Try to keep track of all the stuff that you're learning, either in a OneNote or on Anki or both, like I do. And I hope this was useful for you guys. I hope you guys enjoyed watching this video. I'll see you in the next video, and peace.